Thank you, Mr. Chairman, and I do appreciate the approach that you and the ranking member are taking in asking that we move forward in an appropriate fashion to address the issues. We want you to succeed. We want this to work. And I sense the frustration that you have with regard to the 40-mile rule, the definitions that are found within statute, and the expectations of you in order to make this thing work. I'm just curious if it would be appropriate, should we actually look at modifying the statutory guidelines that are found within the legislation to begin with and change it so that you don't have that issue in the future and that the 40 miles is not going to be audited, written up, and challenged again in the future. It may be something that we may want to look at. In South Dakota right now, we've got, we're East River and West River, and we divide our state up that way, and everybody in our part of the country knows it that way. And if you look at East River, South Dakota, we've got 34,000 veterans, 250 of which have actually exercised their choice option and made appointment with a non-VA provider. Out of 19,330 veterans, West River, 61 veterans have used the choice program. So I think there does probably need to be some additional outreach to these folks in that area. We're a pretty good sized state. But one thing comes to mind, and that is that if there are real challenges in terms of getting these other physicians to actually participate in the programs, you've got a real challenge with having 5 different VA programs that you're trying to manage on this. Look, is there something we can do in terms of providing statutory authority so you can maybe cut through some of the red tape? And is it necessary to have 5 different programs right now? Would there be a better way to do this so you can simplify the contracting so that it's easier not just on the department but on the providers and institutions that you're expecting to step up?
Yeah, there has to be a simpler way.
Do you need statutory changes to do that?
The honest answer is I don't know yet. We know we need contractual changes. We've got, between the contracts that are in the longer-term contracts that are locally negotiated, the PC3 contract, which we actually modified to slip choice up underneath it, I think we're going to have to reconcile those two things, and those are going to be contracting actions.
Wouldn't it just make, excuse the term, but wouldn't it be just a whole lot easier for everybody to take a little common sense into this thing here and just decide that we're going to have a single rate out there that we can negotiate with docs and work it through, or is it, or at least to provide you with the ability to do that?
I think the answer is an unqualified yes. Medicare provides for some differences, particularly in rural areas or in particular states, and I think we want to accommodate that because of the challenges attracting providers into those particular locations.
It most certainly would simplify it for the providers, because if they're providing Medicare services now, if they've got a system set up to follow that rate-making process or those reimbursement rates, at least it would make it easier on them to have the same type of an approach with the VA. Would you check, could I ask that you find out what you would need to be able to make that sort of a change and bring it back to the committee?
I will tell you on further reflection, if we were going to come up with a single way to do this, a single program and a single approach, unquestionably, yes, we'd have to have legislative authority, because choice is one of those 5 or 6 channels. ARCH is one of those 5 or 6 channels. Both of those were specifically legislated. And then we've got contract actions to work through on the others.
You've got an issue where you've got a bureaucracy which is pretty overwhelming. And part of it is because you're doing multiple programs.
It is.
Let's simplify it.
Yes,
we agree. Let's get it down to where the dollars are actually going back down to the providers.
We agree.
If we can cut through a whole bunch of programs, simplify it, make one program out of it and save the dollars and actually put them back down in, you may not have that burn rate that you've got right now on the veterans that you are serving.
We agree.
If I could add, one of the things that we're doing is working with a large consulting firm. We've asked them to bring their commercial side that does really nothing but help health plans set themselves up and run in to help us, and they're doing an evaluation right now. I think when that evaluation is done, what we want to do is really get people together and have a conversation about what does the future of the VA purchase care programs look like.
So just to leave it, my understanding is that you would be able to at least look and find out what it would take to be able to simplify the reimbursement and the contracting processes that are there?
Yep.
Okay, bring it back in and let us look at it.
Yes.
Thank you. Mr. Chairman, thank you.